Hey, Dave O'Sullivan here, and in today's video we're going to cover part 2 of our hamstring masterclass. And what we're going to cover in today's video is how to confidently assess a hamstring injury, but not only that, gain the information that we need to know where we start our treatment plan, but also where we're going to start with our graded exposure rehab plan. So as always, the ideal what we want to get our patient back to is to be able to their foot hit the floor, ground reaction forces are coming up, they're able to tolerate their body weight, the hamstring works well with the gastro and the knee to co-contract at the knee joint to give the hip joint an opportunity to do work. So many times in the past I've seen athletes that have come to me that have failed traditional approaches where when we assess their ability of the hamstring to function, the actual hamstring just cramps up. Okay, so then how can we allow this athlete to go back into the real world and expect that hamstring to be able to perform as part of a bigger unit under even more loads? So if you want more information on how to assess the hamstring for load tolerance, head over to www.thegotophysio.com/blog, and there's plenty of resources there to get you started. But without further ado, let's get into today's video and look how we assess a hamstring to get clarity, get good information, keep it simple so that we can take action, help our patient get back to where they want to, but most importantly, we as therapists can have the confidence and clarity to know that we're on the right track. I hope you enjoyed today's video. Okay, so welcome to the hamstring assessment, and we're going to go over this quite quickly, okay? But as I said, the whole aim of this is just to stimulate some thought and just to give you some ways that in the real world you may be able to complement the stuff that you've been taught at university. So the first thing that I like to do with the athlete is I like to establish how the hips, the knees, the ankles, etc. are carrying themselves in a very relaxed state. So in this position here, obviously Pete's going to be quite relaxed. So passively, I like to just get a gauge of how these tissues are. So the first thing I usually like to do is I'll just bring the hip up and I'll just get a good gauge of hip flexion and hip internal rotation. Okay, so hip internal rotation is going to be quite important for a hamstring. So when I flex Pete's hip and when I internally rotate his hip, I'm asking the adductor magnus tissues and all the skin and the fascia, etc. around the adductor magnus to essentially let go and relax. Okay, so if there's some high threshold within the resting tone of these tissues, we may see that in the form of some protective tone where the hip internal rotation is decreased. Now again, remember what I said in the subject of any tissues that may potentially not be doing their job, that could potentially put excessive forces or demands on the hamstring tissues. That's what I'm interested in. Okay, so again, with the assessment, I want to have a fair idea of the tissues that are driving or certainly contributing to the pain experience. But at the end of the assessment, I want a list of tissues that I think are contributing to it so that we can influence these positively, both with our treatment and also with our actual rehab and return to play. Okay, so the hip flexion internal rotation is going to be a test that's going to be very, very useful for Pete. And again, I'll bring the hip up, okay, and what I'm looking to see is can you get that quadricep to the rib cage, and then the internal rotation is going to be pretty important as well. I will check everything. I'll check external rotation, etc. as well. Then I'm just going to have a quick look at the knee, okay, and again I'll just give him some passive flexion of the knee here again, just to see how that knee is moving, okay? Because again, as that foot leaves the floor and it comes through that swing phase, is there again any protective tone around the knee that could be contributing to maybe putting excessive forces onto that hamstring as we come to that terminal swing? Okay, again, just food for some thought, okay? Then I'll check his hyperextension. Okay, that feels good. And then I'm just going to check Pete's inversion. Okay, eversion, dorsiflexion, and again plantar flexion with overpressure. Okay, again, is there any protective tone, anything like that we're seeing? Okay, and again, we need to be careful when we do that because we want to, ask ourselves the question, okay, well, is this tone here now protective of because of the actual injury itself, or was this hair prior to the injury? And that's the $1 million question with a lot of this stuff. Now, moving on to the hamstring itself. So if you pop on your front, Pete, I'll usually ask the athlete, where did they feel it? And again, that's going to give us an idea. Now, if the athlete, is saying, usually they'll be reporting it just feels around here, or they might feel it high in the muscle belly, or they might feel it in the myotendinous junction. Again, that's just going to give us an idea of the area where they feel it, okay? And then, I might just palpate the tissue and see, is there anything carrying protective tone? So when I go into, the mid-belly, like that tissue is quite soft and I should be able to sink through that tissue quite nicely. If I'm met by a lot of resistance and I'm thinking that the nervous system is carrying a lot of protective tone there, I'm going to respect that and I'm just going to take it into consideration, okay? And then a part of my job with my treatment is reassuring the nervous system that it is safe for that tissue to lengthen again, okay? Because again, all I want to do is give the body back homeostasis in an ideal world, okay? So again, I might palpate the tissue and just get a feel. Again, nothing groundbreaking there. Then what I'll do while I have the athlete on the front is I'll just check their knee flexion, okay? So again, can he get that heel to his bum? Because that's going to be pretty important as well. Again, as that athlete comes through with that swing phase prior to terminal swing, okay? Where there's going to be quite a lot of load demands being placed upon the hamstring. So again, I want to check that the heel to bum, checking the ability of the quadricep tissue to lengthen. Is there any protective tone there, okay? And we'll talk specifically about a relationship between the vastus lateralis and the hamstring later on, okay? So now we've established that, we've got a good overview of the nervous system and how it's carrying itself in a resting state here, okay? Now again, we need to be careful. We can't just say, okay, just because he's got this on the bed, that means this when he stands. It doesn't mean that at all, but it's just giving us some clues that we may or may not consider and want to influence with our treatment. Now the next thing I want to do with Pete, if it's a right hamstring pain, is I want to test Pete with some kind of knee heel to bum, okay? So what I'm going to ask Pete to do is, Pete, I just want you to push your heel towards your bum for me, please, okay? And I'm just meeting Pete's pressure and I'm going to put a force that way. Now what I'm looking for here, you may have seen this in one of my blogs that I've done before. The power of intent is very important here. So when Pete pushes the heel to the bum, so Pete push your heel to bum, okay, I want to see, has Pete got it, okay? Is he happy to really push into my hand, or is he very nervous and very apprehensive, okay? And if Pete's apprehensive about actually pushing, then I'm considering, okay, is Pete's nervous system not happy because there's true tissue damage here and it doesn't want to cause further damage? On the flip side, if Pete's happy and he's got good intent here, then I'm thinking, okay, would his nervous system really allow him to do that if there was genuine trauma to that tissue or significant chances of making that tissue worse, okay? So if Pete has good intent with this test, regardless of the pain experience is being felt or not, I'm a little bit happier, okay? I'm a little bit more positive that we might be able to turn around Pete quite quickly, okay? If he's got very little intent and he's guarding, he's go, oh, I don't want to do that, then I'm like, okay, maybe there is a chance that there is true tissue damage here, okay? Or there's some disruption of the fibers, okay? So that's the first thing I would do. I'll be looking at intent. Now, the big thing here as well that I would do, okay, is I would test Pete in this position. So Pete, go again, push, okay? And then I'd want to know what's the difference in the pain output when I plantar flex Pete, okay? So push again, Pete. And very often what I would see in this scenario, okay, is when I plantar flex Pete's foot, is that he may have a decreased motor output, okay? Now, not always. Now, we could have potentially the opposite as well. So what we're doing here, obviously, when we plantar flex is we're just going to shorten the gastroc, okay? So we're going to increase the force generating needs or requirements of that gastroc in this position, okay? So when the foot is plantar flexed, can that gastroc overcome muscle slack and generate enough force to help the hamstring, or is that putting excessive force on the hamstring? So you could look at this test two ways. You could go, okay, I'm shortening the gastroc, so I'm going to put more pressure through the hamstring, whereas actually I would think I would rather take a step back and go, actually, you know what, the gastroc's still going to be doing something here, but can that gastroc overcome muscle slack and actually still maintain a good force output in this position. Okay, so just take that with a pinch of salt, that when we plantar flexion, just because we're shortening the gastric doesn't necessarily mean that we're taking the gastric out of the equation. All these muscles are still going to contribute to this test. Okay, it's very, very hard just to isolate a specific muscle, so keep that into consideration. Okay, if Pete was weaker here at a decreased motor output, then I'd be considering, okay, is that gastroc doing its job? Because when that foot hits the floor, okay, we know that the gastroc is going to want to take some forces away from the knee, generate tension, and then isometrically contract to send that force down to the Achilles tendon, while the hamstrings are going to work under almost isometric contractions as well and send forces up towards the hip. Okay, so when I look at this, I say, okay, is the gastroc doing its job? Is the hamstring doing its job? If one's not doing its job versus the other, then could potentially that have got anything to do with maybe the hamstring experiencing excessive loads? Okay, so just my thought process. Okay, so we've got that. Okay, so just to recap here, we have found that the athlete has got good intent, then we're happy. Okay, we're thinking, okay, maybe there's not true tissue damage here, versus if the athlete didn't have great intent and was very apprehensive, then I'd be suspicious maybe that there was some kind of disruption to some of the muscle fibers, and maybe we would respect that a little bit more. Okay, so again, we get to his pain experience. I might ask people, how does it feel, etc. You could even get a score out of 10 if you wanted to. Okay, then I would ask Pete to pop on his back. Okay, so we've got that. No, sorry, Pete, actually stay where you are. Just one quick thing, if you want to bias some tissues, obviously, so again, if I want to put Pete in an internally rotated position, again, I'm going to shorten these tissues a little bit, which is going to make it a little bit harder for biceps femoris here. So again, we're going to put a little bit more bias towards the medial hamstrings, although biceps femoris will still have to put a motor output. Pete, push up. Okay, so we're just going to see what he's like medially. And then if I externally rotate him, we're just going to help put a little bit of force through the biceps femoris here. So Pete, heel to bum. Okay, good. Where do you feel that? Just laterally, yeah. And then when I internally rotate him, we're just going to put a bit more bias on the medial hamstrings, okay? Can you feel that a bit more medially? Yeah. So again, that's something I may use. Is there potentially an old injury with the medial side, so MCL, anything like that, old groin injuries, etc., where there may be still some decreased motor output or apprehension, that those tissues may not be doing their job, which could potentially put the forces excessively onto biceps femoris, etc. Okay, so that's something I'd be looking at as well. Once we've done all that, we've got a fair idea, then I'm going to get Pete then to pop on his back. And then what I want to do is I want to see the difference when I test Pete now in supine versus prone. Okay, so we've tested Pete in prone. That's going to take into account majority of the torque that he's generating is coming from knee flexion. Whereas in these tests, Pete's going to generate torque, okay, from the hip and the knee. Okay, so there's a co-contraction happening here at the knee, hopefully, where the quads and the hamstrings are going to contract, but also there needs to be a torque generated at the hip, whereas in prone, Pete was traditionally generating torque from the majority of it was coming from the knee joint. Okay, so all I'm going to get Pete to do here at about 90 degrees is, Pete, I want you to push down into my leg as if you're about to raise your bum off the bed for me. Yeah, that's it. So imagine there's an orange under my shoulder here, squash that orange, and then just lift your bum off the bed for me. Okay, now what I would do here in this scenario, come back down again, is I'd like to put my hand on the hamstring in this scenario, okay, especially around the area, not necessarily on the pain where the athlete has the pain experience, but somewhere around the tissues, just to see if there's good intent through the hamstrings. Okay, so go again, Pete, because the athlete can get around this test by actually almost exclusively using the hip. So you'll see that he'll do it, but you'll feel that there's not a great amount of pressure going through your shoulder, that he's almost trying to lift from the hip rather than have any good intent through the knee. Because when he generates torque through here, that's going to cause the hamstring to contract, okay, and work under isometric conditions at some point, and then the hip is going to get involved as well. Whereas if there's not a lot of pressure coming through the shoulder, then I would be suspicious that maybe he's excessively trying to almost arch his back and extend through the hip, okay? So clinically, that's something we'll see. Again, I'd ask Pete, is there any pain here, okay? And then I would go to about, just around that terminal strike kind of angle, Okay, and I'd ask the athlete to do the same again. Okay, and I appreciate where he's lying on the bed, he's not actually in terminal strike or terminal swing phase here. Okay, so then push down again, Pete. Now with that scenario, usually, no, not always, but some athletes will find this more painful. Again, we have to consider, okay, the sciatic nerve is lengthening a little bit more here. The tissue's working out of range, okay? So again, I would ask the athlete, is there a difference in his pain here versus his pain here, okay? Now, the big thing that I will see a lot of athletes with kind of posterior thigh pain is they will have a pain experience far greater in supine rather than prone. So again, remember what I said, if the athlete's apprehensive in prone, okay, then I would be thinking, okay, maybe there's genuine trauma to the hamstring tissues. If the athlete's got good intent and he does feel some bit of pain experience, okay, so let's say he's got a 3 out of 10. Then I pop him on his back here and then I do this test and the pain experience increases to maybe a 6 or a 7 or an 8. And then I do it here and it's the same or it could change a little bit. Then I would be suspicious that the tissues around the hip could be contributing to this pain experience as well, because they're going to have to generate more torque in this position, that when these tissues are stimulated, okay, or the receptors around these tissues are activated, or the nociceptors, that then is contributing to this pain experience, okay, a little bit more. Whereas when he's prone, those tissues, yeah, they will have a stabilization kind of role, okay, but the majority of the work, as I said, will be generated from the knee, okay? Whereas in this scenario, there's torque being generated from the hip and the knee, okay? So if the pain experience is worse in supine than prone, then I'm actually a lot happier, because I know then that, okay, maybe that the tissues around the hip that are carrying some kind of protective tone, are they maybe contributing to this sensitization, whether it's the sciatic nerve or whatever tissues are contributing to this pain experience, okay? So that would reassure me a little bit better if the athlete in supine had more pain than he did in prone, okay? And that's just my clinical experience over the years of dealing with these scenarios. If the athlete had more pain supine, okay, than he did in prone, and he had good intent in prone, then I would be highly suspicious of the hip. And that's where then we would start to cross-reference our assessments, okay? So we'd go through the hip flexion, we'd go through the internal rotation. Is there any protective tone around the ductus magnus? Is there anything at all in the history that makes sense for that athlete to have some kind of protective tone there, okay? Again, we need to consider the pelvic floor, the diaphragm, okay? Do those two tissues have the ability to shorten and lengthen, okay? And again, that's where, you know, emotional components or fear or trauma, etc., like that may cause these tissues to maybe lose the inability to lengthen a little bit, okay? And again, that's just going to take away some kind of movement options, which we're going to go through in the coming months, okay? But for now, if that assessment, and we went through all that and we found, okay, we can bring on that pain experience and it's worse in supine, it's a higher pain score, then I'm thinking, okay, I would definitely want to go about focusing more now my assessment, maybe a little bit more on the hip tissues, and see that when any tissue that generates torque at the hip is involved, that results in a higher pain score than when he's on his front, and the hip muscles don't have to generate enough torque, that it's more the knee and the coming from the knee, then that results in less pain. So I go, okay, maybe that the hip tissues are contributing, are quite a bit involved in this to maybe result in this higher pain score. Okay, so in that scenario, I would be highly suspicious of some protective tone around the deep rotators, glute max, anything that has the hip extend, okay? And again, we can tweak that a little bit where we can externally and internally rotate the tissues as well. Again, a little bit more advanced there with that, but that's certainly something that we may want to spend a little bit of time around the hip, okay? And again, as that foot comes through into terminal swing, we're going to have a lengthening requirement of a lot of these tissues, okay? So as that foot's about to hit the floor, is there any tissues around here that has to lengthen, okay, that maybe aren't lengthening? And again, I'm not necessarily talking about muscle here, but skin, fascia, nerves that maybe are just carrying some protective tone that they're not necessarily lengthening, and then that could transfer excessive force onto the hamstrings, okay? So that's just my thought process with that. So that's the hamstring assessment, okay? That's the stuff that I would do in addition to all your other stuff. So we would still go through a straight leg raise, a slump test, etc., check the sensitivity of all those, check if there's any neural involvement, etc. All your other tests that maybe you've been taught in university, go and do those as well. But from a practical point of view, this is the kind of stuff that I'm looking at to give me clues to extract information on what I'm going to treat in my treatment section, or actually in my rehab or return to play as well. So from that, I'd have clues whether I'm going to focus a lot more on the hip, or whether the initial stage it's all about just reassuring the ability of that hamstring to settle. Okay, if, as I said, in supine the pain was worse, he had good intent, then I would be a little bit more aggressive with the athlete in trying to get that pain experience to settle down pretty quickly. And then the next obvious question to me is, why is those hip muscles or anything that has to generate torque around the hip being associated with danger? Okay, why, when they have to generate torque, is this athlete feeling that a pain experience? That's my next question to myself. That's then what I want to go about figuring out related to his individual story and his subjective assessment. And then we want to go about restoring and reassuring that. Okay, so that's your hamstring assessment. In addition to everything that you've been taught in university, please don't forget everything else. This is just some additional stuff, hopefully to stimulate some thought and to help you put the pieces together. I hope you enjoyed today's video and it's given you some thoughts. As always, I like at thegotofysio.com to keep things very, very simple. I don't want to sound smart on YouTube or Twitter or Facebook or anything like that, and you can implement this stuff in the real world. As always, keep things simple, clinically reason at all costs, and ask yourself the question, what in the patient's injury history is stopping them from being able to achieve this? So the assessment gives us big clues so that we can now effectively explain the problem and solution to the patient. But not only that, we can design a step-by-step graded exposure program that's going to get back the person to the activities that they want to do with thoughtless, fearless movement. I'll see you in the next episode, where I'm going to reveal one of the biggest hidden jokers that's going to stop you getting this result with hamstrings that I've seen in professional sport over the last 12 years. See you next time.